Oh, welcome everyone. My name is Trina Becker and this is Beth Bergstrom, and we are your presenters for Speech Therapy PD for the Epic Case miniseries. Before we get started, we have a few items to alert you to. In regards to CEUs, this course is offered for 60 minutes or 0.1 ASHA CEUs. We have some financial disclosures that we need to go over with you. So Beth and I have intellectual property rights to our B&B SLP Teachers Pay Teachers store and our B&B SLP website. We're super excited to be presenting to you tonight, and we welcome those that are joining us on YouTube. If you have any questions during the presentation, please put those in the chat and we will either answer them during the presentation or at the end. So, as I said, I'm Trina Becker, and this is Beth Bergstrom. We're both university professors at Eastern Illinois University, and we both teach undergrad and graduate courses and do supervision within our clinic and have over 20 years with assessment and intervention with a variety of communication disorders.
Yeah, we're excited to talk to you tonight. So let's get started. All right. So we're excited mostly because this is not just going to be a one-time thing for us. This is a mini series of case studies, and we're calling them epic case studies. This one is going to specifically be regarding childhood apraxia of speech, but over the mini series, we're going to be talking about ways to work through the whole planning, assessment, and coming up with the client-specific intervention for any and a variety of cases. So that's kind of the framework of what we're looking at here. So epic case studies, we're going to talk you through in just a moment what that stands for. So we will hopefully get you all filled in with that. Okay, our learning objectives tonight are to critically analyze case history and other information to determine etiology and underlying factors of symptoms, to develop a profile of strengths and needs and functional impact to determine treatment priorities, and also to determine the most effective treatment approach using client values, client judgment, clinical judgment, and research. This is our EPIC process. This is what I wanted to share with you. Again, we're going to be using this exact framework for every one of our 11 mini-series presentations. So it's a guide for client-specific intervention, working through etiology, profile, impact, and finally arriving at client-specific intervention. We think that it's very important to have a checklist almost to ensure that you are considering each of these areas before you just start therapy. You cannot start therapy without truly understanding the etiology and the differential diagnosis of your client. And also we want to really encourage you to think about the impact in every aspect of the client's participation so that you are thinking about the client as a whole person. This whole process or framework, we kind of based it off of the ICF framework that ASHA has available that was put out from the World Health Organization. So this is kind of based on that. Tonight, we're going to be specifically talking about a case on childhood apraxia of speech. We're going to be talking about Milo, a little 3-year, 4-month-old, and the chief complaint by his mom, who gave us permission to share all of his adorable videos and information. The chief complaint was speech intelligibility. Again, if you look at the worksheet that you have in front of you, the guide, you can see that E stands for etiology. We really feel it's important to always start with a case history where you are looking and digging for information on medical and developmental history, on family history, and also thinking about other therapies and other professionals that might have information that you need to make a decision on the diagnosis. So thinking specifically about Milo, our 3-year, 4-month-old, do you want to talk a little bit about how he arrived at the clinic first?
Yeah, so he started therapy just this semester. So that was beginning in January. And as a part of our process, we get case history information so that our students that do the therapy can start preparing for their therapy sessions. And so we have the case history, and then we also ask for any reports from other professionals. Now, we know working in a university clinic that, we have the luxury of getting this case history information from families. And maybe if you're working in the schools, you don't always have access to that. But we really want to encourage you to do that, to get some information about their medical and developmental history, whether that's you or the social worker that gets that information for families as you're doing the assessment, because we feel like it's really important to have that background to dig into what Beth's talking about with the etiology.
So specifically for Milo, medical and developmental history revealed that he had low ferritin blood levels, low iron, allergies, torticollis, weak core. He currently wears braces on both of his feet. He has a history of toe walking, extended pacifier use, global developmental delay. And also in his history, we saw a quote from mom saying that he stopped talking around 15 to 18 months. So all of these things that you see in medical and developmental history, there may be things there that you don't have a clue what they are or how they may be impacting his number one concern, which is speech intelligibility. So you may have to really dig into those things. We had to ask some extra questions regarding her comment on stop talking to get a little bit of clarification there. Looking at family history, important to know that his brother has a history of language processing, executive function deficits, and also articulation delays. He's also been in occupational therapy as well. Interestingly, I currently supervise his older brother, and Trina is supervising Milo. We also looked at what other therapies he has had in the past and what other professionals have been involved. He had early intervention very early on for PT, OT, and speech. He started a blended preschool program in November with an IEP for speech. So he's having speech currently at his school. And he also gets therapy through a hospital clinic as well as ours. We see him twice a week here for 45 minutes. And again, this spring is his first semester with us. So he's getting speech in a variety of places. And I believe he's also still is receiving some OT either at school or at the hospital. So, I mean, he's getting a lot of therapy. You're going to see some video clips of him coming up where, you can tell that he has been in therapy before. So I think it's really interesting and important to be thinking about those things from etiology.
We did look at the reports from the school and from the hospital SLP and noted what they were doing for therapy. However, we wanted to dig in and do our own assessment, and also for our students. Part of the process is to do assessment at the beginning of the semester, specifically for a new client to get that actual diagnosis. So we did have some information. We'll kind of add more into that as we go along. But we wanted to do a full comprehensive assessment for Milo to do the differential diagnosis, which actually was perfect so that we could use them for this case.
Yes. Okay, so the E for etiology. Now we're moving into the P for profile, but we need to start that profile with taking kind of the key findings away from the etiology. So everything that you saw on the slide before, we kind of need to summarize here and say what from that information is really important for us to know with regards to what our therapy might be with Milo or what our plans are for assessment. So we took away from etiology his overall concerns for what we are calling mixed tone. He has some low tone and he also has some hypertonicity in some of his limbs. So he has global delays that have been documented from early intervention and on. And both of those things kind of lead us to the possibility that we're looking at some neurological concerns.
So when we're thinking about diagnosis, like you said, these are the things that we want to take away and take note of. What's going on with this mixed tone? How is that impacting his speech intelligibility? And then that information altogether, leading up to possible neurological concerns, can start you thinking about, well, it might not just be articulation, or it might not just be phono. It could be, but it might not be.
And also really important to know, again, we're in, I think, week 6 or 7 of our semester, and we have literally taken 6 or 7 weeks to come to our diagnostic conclusion, which we'll be able to share with you tonight. But it did not happen overnight, and we are considering a lot of and a variety of features and factors. Okay, we're getting to the part where we want to show you a little bit of Milo's assessment. So I think maybe now talk a little bit about how you decided what assessments to give, which assessments to start with, and your considerations for that.
Yeah, so we went through the case history, right? That's the first thing we did, and then also did the interview with mom. Speech intelligibility, it kept coming up. He's highly unintelligible. He does not use very many different phonemes, mom shared with us. He doesn't use very many syllable shapes, and he is overall just very difficult to understand. So when brainstorming through what assessment that we were going to give, what standardized assessment we were going to give, thinking about, are we going to give an articulation test? Are we going to give a phono test? We decided to give the HAP because his speech was so unintelligible. So we suspected there could be some processes going on. And also due to his age, being 3, we felt like the toys would be a good, and the props that go along with the HAP would be good for maintaining his attention.
Yeah.
So we wanted to do a standardized speech sound assessment as a top priority, and also an oral mech as a top priority. So then when deciding what to do first, we picked the standardized assessment for our first session. Well, actually, we did rapport building our first session, and then did assessment, because we just didn't want to start digging in his mouth and kind of turn him off.
Very invasive at times to do that. And also, I think, just to this point, because of his age and because we described him as, significantly unintelligible to others, I mean, we are a lot of times thinking about phono at this point, in the process. Looking at his case history kind of alerted us to a few other options. So we were like, we're just not sure. But the HAP, no matter what, is still a great place to start, because it gives you structured words for you to really get trends and errors. So it was a great place to start.
You mentioned we were thinking phono, of course, and the etiology alerted us to that. I also wanted to say, looking at his reports and knowing that he's had therapy for speech since he was in early intervention, early on. I mean, he's had speech for a good 1.5 years, maybe almost 2 years, and he's still highly unintelligible.
Yes.
So that should raise also some red flags, I feel like.
Absolutely. Anytime you have a lack of progress, and you need to really say, are we doing the right things? Do we need to reconsider?
Yeah. Okay. So let's look at his oral mech. I know we did the HAP first, but I feel like I want to start with the oral mech. And when the student, after she did it, she came in, or actually I just read her SOAP note and reported, no major concerns with the oral mech. She did have a little bit of difficulty getting him to follow directions because he kept wanting to imitate everything that she said, which I think is because he's been in therapy forever and been practicing speech. And so she was like, it was a little hard sometimes to get him to stop imitating.
And you'll see some good examples of what we're talking about with that in the oral mech.
Imitating my directions, she said, and having him do it. So I then watched the oral mech, and then the next day called Beth into my office and be like, okay, you have to take a look at this. I'm seeing some things, and we're going to show it to you first, and then we'll talk about those things, but things that I wanted her to look at, to brainstorm about, and to also just share. So let's take a look.
Okay. We're going to show you about a minute of this, and then we're going to talk about it and maybe show you again.
Show me how big you open your mouth. Can I see in there? Open it up. You got any food in there? Let me see. Can you open big? Open big like a crocodile. Good. Okay. Now we're going to have our mouth big and open. And then we're going to take a bite, like we're taking a bite of food. Ready? Watch Miss Tristan. Now you show me. Can you take your finger out of there and show me? Okay, open your mouth big. Good. Okay. Now we're gonna pretend to blow out our candles. So we're gonna go. You show me. Good, Jen, begin. Good. Okay. Now we're gonna smile for Miss Brooks' camera. Smile. Good. You have such a good smile. Now we're gonna make our ambulance noise. And we're gonna say ooh-wee, ooh-wee. You tell me. Ooh-wee, ooh-wee, ooh-wee.
Okay.
Go ahead.
Okay. So some things that I noticed right from the beginning. It looked a little bit effortful. Even when he just was asked to smile, I mean, that should be something that is not something you have to search for. But we saw some groping behaviors with that. You saw what we talked about, that he almost wanted to imitate her last word versus do the skill that she was asking him to imitate. So there's just a lot of coordination and planning things happening there. When he did do the smile, you will notice, as we show you again, a lot of extraneous movement of the eyes. When he was trying to do that skill, he wasn't just able to give the smile quickly. Just opening and closing his mouth was not fluid. He had difficulty programming that and kind of getting that sequence coordinated. And again, I'm seeing those things as I watch, as you did when you watched. But the clinician who doesn't have a lot of experience with recognizing these things, her first impression was to say, well, he did do them all. He did all of the skills for us, but was not focused in until we kind of alerted her to those things, that he was using extraneous movement. He wasn't able to isolate movement of his articulators, that he almost, you even see him kind of like turn away from the camera as he's trying to kind of get some of this stuff programmed. So, I think it takes a lot of digging in with a video. So it's always important to record your oral mech so that you can watch it later, because in the moment you feel like things are going pretty well.
Yeah, I mean, it goes fast, right?
Yeah.
You have them do the thing and then they're on to the next, especially with a 3-year-old. You can't take a lot of time in between, each item to write things down. You're going to lose their attention. So we really feel it's very, very important to do that video of the child so you can go back and watch. Okay, so now that you know about, we're looking for groping. We're looking for some planning things as he's trying to get to the different movements. You're looking for extraneous movement of his body, his eyes, his face, his shoulders even, as he does these first few movements.
So take a look here.
Big like a crocodile. Show me how big you open your mouth. Can I see in there? Open it up. You got any food in there?
And again, I think it's important to note that he did open his mouth wide. You saw that, but he couldn't do it in isolation. He was using other things, sensory things, to kind of help him complete that action.
Let me see. Can you open big? Open big like a crocodile.
Look at him search for that position.
Okay. Now
And
we're
he's
gonna
using
have our
every
mouth
technique
big
possible,
and open,
visuals and some
and then we're
tactile
gonna take
and
a
modeling.
bite, like we're taking a bite of food. Ready? Watch Miss Tristan. Now you show me. Can you take your finger out of there and show me? Okay, open your mouth big. Good. Okay. Now we're gonna pretend to blow out our candles. So we're gonna go.
I even see a little bit of like sucking in the bottom lip as he's trying to blow
Good,
air
Jen,
out.
Good. Okay. Now we're gonna smile for Miss Brooks' camera. Smile. Good.
And you see his eyebrows and
You
his
have such a
eyes and his
good
cheeks,
smile.
everything.
Okay, the next piece we want to show you are his diadochokinetic rates. So this was eye-opening, this part. I mean, definitely we saw some things at the beginning, but also his diadochokinetic rates are really important to watch and note his rate, note his consistency in his productions. What else are we paying attention to? I'm trying to remember.
Let's let them watch it first, and then we can go back and look a little bit here. You mentioned that you'll see him do a few isolated, and then we'll try to get to some of the sequence. Yes.
Popcorn sound. Popcorn sound, right? I gotta find the right timer on my watch. Oh, wrong one. Here we go. Okay, are you ready? So I'm gonna show you first, and then you're gonna do it. And we're gonna say them super fast, okay? I'll go first. Okay, is it Milo's turn? Okay, Milo, ready, set, go. Keep going. Keep going. Keep going. Do it for a really long time. Good job. Okay, are you ready for our next sound? Our next sound is our tapping sound. So this one's kind of like our first one. We're going to say them really, really fast. But this one is going to be this. You ready? Okay, your turn. Ready, set, go. Oh, someone hit your face. You're going to hurt yourself. Try again. Show me how fast you can do it. You do it. Good. Okay. Our next sound is our cut sound. So our cut sound sounds like this. Okay. Is it your turn? Okay. Ready, set, go. Good. Keep going. Keep going. Keep going. Good. Okay. This is our last one. And this is, we're going to say this one. We're going to say this one 10 times. Okay? This is pada cake. Pada cake. Pada cake. Okay, let's see if you can say it 10 times. Ready? Go. Pada cake. Say it again. You say it again. Pada cake. Okay, say it again. Good. Pada cake. Pada cake. Pada cake. Pada cake. Pada cake. High fives. Good job. That's it.
Okay. So no lack of effort on his part. He is definitely trying to get all of those sounds. It's almost painful to watch him try to use every part of his body to coordinate the target.
Yeah, when he was saying patty cake, it came out different almost every single time. Pada ka, and then papa da, and then pa. I mean, it was all over the place. So your alarms should be going off right now with these inconsistent productions and the coordination of movement. He had major breakdown when we started to try to coordinate 3 different CVs.
You're also taking note of the fact that he still struggled even with just CVs, pa. But as that complexity increased to the pa to ka, I mean, it got even more difficult for him. So he was, you know, again, like you said, your alarm should be going off. You should be thinking primarily about the difficulty and the inconsistency and how much that's impacting his ability to be intelligible with any word or phrase.
And the clinician was really struggling because she was like, I didn't know how to make him do it on his own because he was always waiting for her to do it and wanted to do it at the same time as she did or wanted to do it after direct imitation. So we know that part wasn't perfect. For sure, you want to get them to try to do it on their own without direct imitation, but she was really struggling in that moment. And honestly, we saw enough.
Yes, saw a lot. Yeah.
You know, with direct imitation, he was still really struggling with that piece. So, yeah, definitely some concerns with this oral mech and should be really starting you to think about, okay, this is probably more than just phono. So next we have up the HAP, and we're going to look at the results of the HAP. I will tell you, I don't have the exact scoring of the HAP up there. Just know that he did have multiple processes. A lot of them were due to omissions of sounds. And I have put here for you to see some vowel deviations. I just pulled out a few words, not the whole HAP. But let's look at that first one, basket. The underlined vowels, you can see he said iba for basket. So we have two vowel deviations in that word. Candle, he said kika. So that E vowel he produced instead of the A. In clouds, it was just ah instead of ow. Instead of in feather, he said E. Instead of in glove, which is a neutral vowel and should be easy, he said go. So a lot of vowel deviations happening here. Again, we didn't get hardly any spontaneous. It was all direct imitation because he just didn't do a lot spontaneous. And we tried to take his first production and noticed even on second productions, he was inconsistent with how he produced the words. On not all of them, but on many of them. Probably for time's sake, we should go to the next one. Okay.
Basket.
Okay, so after the HAP and after the oral mech, we wanted to break down things a little bit further, and we are already starting to suspect apraxia here. So we wanted to see how Milo did with vowels in isolation and also some CV productions to see if we still had vowel deviations. And also we wanted to take note of any inconsistencies. So we did some informal assessment and did the different vowels and did the different consonant vowel productions here. So kind of similar to what the Kaufman assessment would do, we did it informally. So this first video is of him doing the oo sound. So your first target is boo, and then you'll listen and hear him do it two different ways. The next is moo, and the third one is new.
Working. Boo. Boo. Good. Moo. Moo. New. New. Two.
Yeah, I just think it's so interesting to hear how he changes it just with two productions in a row. They changed significantly, and neither of them were the target. So, I mean, I just feel like that's really interesting. She and I listened to these several times. I mean, we had a few very small differences in kind of how we were hearing his vowel, but it didn't change the fact that they were different every time. They were never the target. So that was really telling.
And I think our most differentiation was versus just the neutral
Yeah.
So that was the oo sound. And then to the right, so that one is o. So now he's doing mo.
First we have to say mo. 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 Very good job.
Yeah.
Okay, and then this other one is me. And for this one, he did it correctly twice. The third time he said it, he did a B for the M. And then he went back to the M.
Me. 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 Good job, Milo.
And then finally, the I sound.
Why? Why? Good. Trying.
So as soon as we saw this one, we started to talk about, okay, what is he never doing? What can he not doing? So very quickly, Trina was able to pull up this chart of front, center, and back vowels, along with kind of what your jaw is doing, which led us to lax and tense vowels. So what did we find about kind of what he was never doing?
He was never doing ooh. So if we look at that, that's a back high vowel. He had difficulty with O. That one was definitely not consistent. And then the diphthongs aren't on this chart, but he did have some difficulty with the diphthongs, which is interesting because sometimes he made the pure vowels, he made them diphthongs. So he's kind of all over the place. So we were just really starting to dig in and go nerding out over this vowel chart. And what he was doing.
This is a really important process to go through if you're going to determine what goals to start with. So as we start to get to client-specific intervention, this is going to be really important.
Talk about his jaw.
Oh, I just don't ever really see him lower his jaw. We watched one video where during the oral mech, I think that he was actually lowering it, but when he's producing sounds, he keeps it pretty much closed. So I think that that's going to also be a target as we look at tactile cueing that might come into play for, under the Apraxia framework of things we need to think about. We're going to have to teach him to lower or drop that jaw in connection with a vowel production.
Working me.
Got it.
Okay. So after doing the HAP, we wanted to do a syllable shape inventory and look at what phonemes that he was producing. So Beth and I, 2 years ago now, almost 2 years ago, we developed what we call the Copycat, which is a differential diagnosis tool for speech sound disorders. And really what it does is pull all of the information together from all of your assessments and puts it in these nice worksheets to really help you analyze it. So right here, we're showing you an example of our syllable shape inventory. We got this information from his HAP and also from that informal assessment that we did with his syllable shapes. So Milo consistently produces CVs. And then his CV productions, I would say, are still emerging. They're not solid yet for him. And his CVC production is also still emerging. He rarely puts final consonants on, but he does occasionally. And then the more complicated syllable shapes you see at the bottom, he's not doing those yet. In regards to his phoneme inventory, we do have a worksheet in the Copycat for this too, but here's the summary. He does mostly his early developing sounds. So you see his stops, nasals, and glides here, which are those first sounds that kids develop. So he has a pretty good inventory. Well, I don't know. He's got his early developing sounds, let's say.
And I'm sure that those have been targets for him in the past as well.
Yes. So there's that.
And then just pulling the profile all together. So again, taking all the information from assessment data, we just said, we know that hearing is within normal limits. We made sure to check that. If you're going to do a comprehensive evaluation, you always need to include hearing and oral mech along with any other assessment that you do. We found a lot of problems within the oral mech exam. So groping, in coordination and planning concerns, extraneous movements of not just facial features, but we felt like whole body, and definitely difficulty isolating articulators. His speech sound assessments showed us limited phonemes, limited syllable shapes, multiple processes, as Trina mentioned before, mostly omissions, and those vowel errors. Assessment also includes stimulability. If you're going to be writing goals, you need to know what he's stimulable for. So stimulability, inconsistent productions on repeated attempts was identified through the profile. So now using that profile to talk more about looking for trends, looking for characteristics, Again, part of our copycat that we use for differential diagnosis of speech sound disorders includes these two forms, descriptive features and our kind of copy profile that puts it all together for distinctive features. So for speech sound disorders, kind of the things we're thinking about here are articulation non-structure, articulation structure like cleft palate, phonological, apraxia, and dysarthria. So, you know, we're somewhere here in one of those areas. What is it going to be? As we use the information that we get from our case study or our case history, our oral mech, our phoneme and syllable inventory, and our error analysis, we can put check marks everywhere that we find he is being described with these descriptive features. So for Milo, he had poor intelligibility. We learned that from our error analysis and our case history, according to Mom. We know that he has abnormal motor control, which we learned from the oral mech exam. So you can see already that those characteristics are shared between more than one diagnosis. Limited phonemic inventory, we know from the phoneme and syllable inventory as well as our error analysis. He also has limited syllable shapes that we also learned from those two parts of our assessment. He has vowel errors that we learned from those two parts of the assessment. And then also we felt like he had some prosody timing errors. We saw those kind of after watching the videos multiple times, but we did notice those. So again, you can see all of the overlap in these descriptive features. So we have to have some other way to make our differential diagnosis. If you look over to the left and look at the copy profile, you'll see that this is where we're going to be really thinking about the case history, the oral mech, and then also thinking still about some of the error analysis. We know that he does not have any structural deficits. We know that from his oral mech and from his case history. So it rules out articulation structure. If I jump past our X, we know that he does not have any weakness. From our oral mech exam, we did not see any weakness. We did have reports of low tone, but not any problems with range of motion or with any drooping or inability for muscle strength. So that ruled out dysarthria. And then we look at the majority of phonemes. We know that, or majority of phonemic errors. You know, we talked about the fact that he does have some final consonant deletion, but we felt, again, we're going to go back up now to our other option here, but also ruling out any of the articulation disorder because it wasn't on any specific motor patterns. So
can I jump in for a second? For the phonemic errors, for the processes, I mean, they showed up on the HAP, but as I talked about, they were mostly omission. So we didn't see processes of stopping and gliding necessarily. There was a little bit, but those weren't the primary thing, right? That was causing his intelligibility issues. And because it was a little bit all over the place, those rule-based errors, you couldn't really establish it as a rule-based error.
Right.
So that's why that's not checked.
Okay.
I just wanted to kind of clarify that because
yes, thank you. So if we go back up to where we see planning errors, groping, coordination, inconsistent productions, those are all the things that we were able to find trends for in our assessment. And it kind of leaves us here with a differential diagnosis of apraxia. Again, in using this information to not only write goals, but also to include in the report, really important to know that wherever your descriptive features are probably going to be key goals in the future. So we really like the way that this is all kind of shown in just one or two pieces of paper that we can kind of go back and forth and make our final decisions. So We also want to specifically have you look at your handout at the I. So now we're up to impact. Again, this part of it, I think we learned mostly from that ICF framework that ASHA has put out for us to do comprehensive kind of assessment before we write goals. So I really like this impact kind of part of it where it says specifically you need to think about each of these areas and ask yourself, are there problems in any of these areas before you determine what your priorities are. So the first one is auditory comprehension. And I would ask, Trina, does he have any problems with auditory comprehension?
No.
Oral expression?
Definitely.
Cognition?
Nope.
Speech?
Yes.
Social?
We think that his speech is really impacting his social
Okay.
with his in his preschool.
Absolutely. Behavior?
No, man, this kid is a hard worker.
Sensory?
Nope.
Written expression?
Nope.
And reading comprehension?
Nope. Not yet as a 3-year-old.
Right. And some of those things may need to be revisited. Of course they will at a later time. We would want to kind of revisit that, but now those are not the things. So the things that we checked yes were oral expression, speech, and social. I also love the clinical questions that are directly below the impact kind of graph there. So the clinical questions are, what impairments most impact daily function?
His speech intelligibility.
Okay.
And oral expression, right? Just him being able to express himself.
Yeah. What activities are most important to the client? And obviously this is kind of per parents.
Sure. Mom wants him to be able to participate in preschool, to be able to interact with his friends, to be able to answer questions. And they really have a hard time communicating with him at home too because of his speech intelligibility. So definitely that's a concern for them.
They have a really close, tight family. And I think they really fill in the blanks for him because they don't want him to struggle also. So what current characteristics hinder the client the most?
His speech intelligibility.
And what current characteristics are strengths to build on?
He's a hard worker. He has a great attention span for a 3-year-old, and he is so motivated to communicate. I mean, that child will sit at the table and work for 45 minutes. So those are great strengths for him in terms of prognosis, I think, for speech therapy.
Absolutely. And again, you would say, are you sure? Because he's been in speech therapy, through early intervention and hasn't made progress. But then what we're going to say to you is, but now we know what we need to specifically work on and where we need to start.
Also, I think if he did not have a good attention span and was all over the place, I can't imagine what therapy would look like.
Yes.
Oh, so then we were figuring out, what do we do now for intervention, right? And what goals are we going to write?
So are you an apraxia expert?
I am not an apraxia expert.
So where did you even start for this?
I dug into the literature, and I don't know if you guys have read the book, How to Treat Apraxia of Speech, or Here's How to Treat Childhood Apraxia of Speech, by Margaret Fish, but both of us have heard her present a few times, and this is a great book. I know that they also use this in our graduate level course, in their speech sound disorders course. So we started there. Yeah. I started there. The clinician started there, reading about apraxia, reading about assessment, and then reading about the intervention piece. And so Dee Fish, so she goes by Dee, she came up with this framework, this PRISM framework. And so that's where we kind of started in thinking about both the goals and the intervention piece. So her PRISM framework, one of the things is phoneme sequencing. That is the P. And so when trying to think about goals, we needed to consider phoneme sequencing, which leads us to thinking about word shape difficulty. So we have this hierarchy of word shape difficulty. And there's our resource for that. So starting at the simplest level, and it's recommended if a child has issues with vowels that you put it with a consonant, that you start at that CV production, because what we're doing is working on planning. And so we need to pair it with a consonant. So we use this hierarchy to help us develop our goals, figuring out where we needed to start with Milo and where we were going to go next. And then we embraced the concept of R for repetitive practice. We knew we were going to do a lot of drill in our therapy sessions, intensity of services. He comes here, he goes to the hospital, he goes to school. So we are going to coordinate with all of those SLPs. You're going to see how we incorporated the selection of target utterances into his goals. It is in the literature of apraxia that you need to consider functional words for that child and high frequency words. And we want them to have to practice on those words the most so we can get them intelligible as quickly as possible.
And that keeps him motivated as well,
Yeah.
having those high frequency words.
And then finally, the concept of multisensory cues and feedback. So I'll bring that back in just a little bit. So let's look at his goals.
Okay. And I just wanted to say that, we always kind of start with we start with a framework. What is our key teaching strategy that we're going to work under? So we don't start with goals. We start with what is the framework that we want to work under. And the framework that we are kind of adopting here with this client is the PRISM.
Okay, so here are his goals. We want him to make accurate productions of our CV syllable shapes with pure vowels. So those are the vowels, not the diphthongs, just the regular pure vowels. And we want to use the consonants that he can produce. So another concept in apraxia therapy is that you don't want to introduce a new phoneme with a syllable shape that he doesn't have established yet, right? So we want to use the phonemes that he has to work on these syllable shapes. So that's why we chose those phonemes. And then next, we want to do CV syllable shapes with the diphthongs. So I really feel like we need to get the vowels perfected because that's the foundation, these CV productions, before we move on to the next one. So I felt like I like to write really specific goals so I can check them off. So instead of just doing one comprehensive goal for vowels, I did it into two.
Right. And we really do want him to build consistency with the first goal before we move on to another. Okay.
And then we move on to the CVC syllable shapes. And within that, we're going to work on accurate productions of the CVC syllable shapes and high frequency functional words. So here's where our words are going to come into play. We're going to be very thoughtful about the words that we choose for him. Probably going to be interviewing the parents, thinking about what does a 3-year-old need to use to pick our frequency words with those phonemes, again, the phonemes that he has. And then we're going to move on to the CVC syllable shapes with the same things. Okay, and then now what are our methods? So we have our goals. Now what are our methods? So we chose to use the DTTC strategy by Strand and Skinner. So this really builds upon the motor speech hierarchy as well. And so here's just a little snapshot. This is abbreviated procedures of their methods. So we're going to start with direct imitation. If the child does that production incorrect, then we're going to go to simultaneous productions. He's going to do it at the same time as us, slow down our rate, add in cues, and we have all sorts of cues that we're going to think about, multisensory cues, and we're going to continue to do that until he can do it without errors. And then we go back up and do direct imitation again. And if he can do it correctly, then we're going to move to that other side and start increasing the rate and then begin to vary rate and prosody. Again, the key is planning, right? We have to get the planning down. That's his core deficit area that we have to really target.
And again, if you were not specifically thinking about methods, you might automatically do some of the direct imitation, do the modeling. You might even try some of the touch cues, but having this specific guideline that's proven through research and evidence is really important to find this to work from. You shouldn't be reinventing the wheel. You should be using your resources. So we really think that it's most important to start with some kind of framework, write your goals, and then you really need to dig into what are my methods going to be.
And the ASHA Practice Portal has information that you can use as well. We went there also to look for articles. These are some of the multisensory cues that we're going to try, and what you want to do is try to find what are the multisensory cues that work best for your client. These are different kinds of cues that you can try. And then finally, that last piece of that PRISM framework is the specific feedback. So we're going to give Milo frequent, immediate, and specific feedback, and the feedback is going to be related to his movements and describing what is going on with his mouth and the movements that need to happen to produce that sequence of sounds.
Some of the methods here too, she mentioned collaboration. I mean, if he's going to be getting therapy in 3 different places, everyone needs to probably be on the same page with regards to cues, including parents. You know, we really encourage our parents to watch and hear our feedback so they know what they're looking for and what they're listening for.
Okay, so we hope that we gave you the EPIC framework for how to walk through a case. This presentation wasn't to teach you about apraxia therapy,
Even though there's a lot of great information in there for you.
but so much more to dig into, but just to how to tackle a case from etiology to try to get you all the way to that client-specific intervention. So now
we are hoping there are a few questions here. So let's check. Oh, yeah, this was great. You guys were kind of joining in during the oral mech and telling us what you saw, really saying that you saw a lot of problems with his productions of ta-ta-ta, wondering about if he was getting any lip rounding. Someone said, was Milo cueing himself during the HAP and the oral motor? I really did see that as well. He would put his hand here, almost put his hand in his mouth to try to assist with some of that movement. We definitely, do you guys still see that with him?
Yeah, and I think, like this person commented, I do think he's learned that from his other speech therapy session.
Yeah.
His hospital SLP is working on some of the same things, and she is using cueing, so I'm sure that he has, you know, started working on that. So yeah, he's definitely cueing himself, and obviously he's imitating like crazy. That is a strategy. I think he's really trying to watch their mouth, watch the speaker's mouth, and imitate exactly what they.
And honestly, it almost has gotten in the way a little bit, I think. And especially it's distracting for the clinician as she's trying to get him to do some of these imitations. So we need to figure out a way to kind of either kind of have that fade away. So as you're doing some of your DTTC cueing, you may have to spend some time actually kind of training him to wait and do his imitation. However, and even simultaneous productions, I'm not sure he would get the idea of that without some specific explicit training.
Yeah, he will. He definitely will.
Yeah. So someone else said the EPIC framework. Again, we feel really passionate as professors here at our university. You know, we can't teach our students about every single disorder area and every single strategy and framework. We really want to mostly teach them how to work the process from beginning to end in a comprehensive way, making sure that they are considering all of the important pieces before they just go and write a goal. So, I mean, again, that's what our whole kind of idea is as we work through these cases. The cases are interesting and they are valuable in kind of teaching you those things. But in the end, our idea is to really make you think, am I walking through etiology? Am I developing a profile? Am I thinking about how this is impacting the child in every area and then choosing the priorities before I start writing my client-specific goals? And I say client-specific intervention, client-specific goals. You can't just pull goals out of a book, you know, that are apraxia. There's many different options based on, you know, what you're seeing with your individual client. So that's our kind of hope as we kind of walk through the next 10 after tonight, our next 10 cases is to really make that become automatic for you. I'm automatically thinking about etiology. And if right now you don't have access to that kind of thing, start to think about how can I make that something that I always have access to.
I see somebody has their hand raised. Best with this format to put your question in the chat so that we can see it. While we're waiting for that question, I wanted to talk about if we didn't differentially diagnose Milo and we kind of came in with the idea that he must be phono because of his poor speech intelligibility, our treatment would have been all wrong, right? Like the core deficit for apraxia is motor planning. Phonotherapy is not motor planning. Phonotherapy is language and rule-based. And I would think that therapy would take so much longer for him to improve his intelligibility of speech had we gone with a phono diagnosis and chosen that approach.
Yeah. We have a couple of questions here.
Okay.
It says, how do you work on differentiating the deficits that are coming from autism versus childhood apraxia of speech? The imitating could be more from difficulty following directions, echolalia, or not, or sensory from extraneous movements. Sorry, so rush to ask. That's okay. We totally understand where you're coming from, because we made sure to ask ourselves those questions.
Yeah.
We do a lot with kids with autism here in our clinic as well. And I think one of the first things, we really never went to autism for this particular client, but I know that we said he looks like he can't follow commands.
Yes. And you said with the imitation piece, oh, I could see how this looks like autism.
Yeah,
because
absolutely.
it looks like that echolalia. But taking in the full picture of Milo and looking at, oh, does he have those repetitive behaviors?
Right.
Looking at his social skills and all the things, we could rule autism out. But
Right.
I can see by those little things that you mentioned, he could look like he has autism.
Absolutely. And it's an important question. And I really think that using kind of this worksheet of considering etiology and impact, you would then be able to kind of rule out or rule in whatever, you're kind of considering. Another question here about any tips for doing a comprehensive assessment with only an hour evaluation time slot. I work in private practice and I'm rushing with 3-year-olds.
Okay, I got it.
Okay.
We're going to do the oral mech. That needs to be priority, right? To figure out the cause. You have to do an oral mech. And then I would say either choose, this is my opinion, you can add yours
Okay,
in.
I will.
You could choose a standardized speech sound assessment like the Goldman-Fristo or like the HAP and get it, but then apply it, like really analyze it. Because what you're wanting to know is what are the phonemes that they're producing? What are the syllable shapes they're producing? And compare that to developmental norms. And then one more thing, if you can squeeze that in your hour, I want to see some stimulability testing. I want to see the child doing multiple repetitions of the same word, so you can look for the evidence of inconsistent productions if they have it.
Yes. And I think oral mech was the first thing she said, and I would agree. I think my students probably hear me saying that in their sleep, doing oral mech. But diadochokinetic rates are part of an oral mech exam, and you really, that was kind of a turning point for you with this particular client. When you saw how difficult it was for him to do those diadochokinetic rates, you were like, okay, this is a key factor that is impacting him. So I think even for a 3-year-old with limited time, you have to find a way. It's not easy. It's not easy to do an oral mech, but it needs to be your number one priority. When speech intelligibility is a concern, it needs to be your number one priority.
And I think that took her 12 minutes to do that and get that from him. And the HAP takes around 20 minutes, maybe depending on the kid, maybe 30 minutes. And then if you can add in a little bit of repetition where you're doing, words over and over to get over and over again to get that stimulability, I think you have all that information then to think about the profile.
Yeah. So, and the copycat that we have available is really nice for helping you think about what you need to analyze by putting, that information into the copycat. You don't need the copycat because you can use all of your standardized tests. What we like about the copycat is that it puts everything in one place so that you can really then pull it all together at the end. And also the etiology and case history information was really, really useful. And you don't do that when you're in the session with him. That's going to be done outside the session. So even that time that's not spent in the session, you're going to get a lot of useful information.
If you're wondering where to grab the copycat, it is in our Teachers Pay Teachers store, so you can find that B&B SLP. That's available there. And we have a presentation on speech therapy PD about the copycat. So if you want to know more about differential diagnosis, we have a whole presentation on that where we walk through a phono case, an apraxia case,
structure, cleft palate case.
Yeah.
Dysarthria.
The extra good information there.
Yeah.
All right. I think we're running out of time. Please join us for our next EPIC case. It's also on speech sound disorders. So look for that. We really appreciate you joining us tonight. We thank you so much for the questions. It makes it so much more interactive when we can hear from you.
Okay. Do you guys want a little teaser for what our next case is going to be? I think it's gonna.
Yes.
You do?
Yes.
Okay. All right. I think it's going to be on cleft palate speech and differential diagnosis of cleft palate and some other speech sound disorders. So, of course, it'll probably be a case of mine. It tends to be kind of my thing. So we'll go back and forth. But moving forward, we do have some language disorder cases. We have some gestalt language processing that we're going to be looking at, some AAC use. So there's a variety of disorder areas coming. We're going to stick with speech sound disorders for the next couple, and then we'll move on to some other areas. So again, thank you so much for joining us. We're excited to hopefully be seeing some of the same names in our next presentations, and reach out to us on our socials if you have any specific questions.
Find us at B&B SLP. We're there. We'd love to hear from you.
All right. Good night, everyone. Have a great evening.